It's Daniel, and I'll be the moderator for this session this morning. Um, I'll be answering questions or collecting your questions in the question box, which is on the right of your screen. If you have questions for the presenter during the presentation, you can open up that box and enter them there, and leave any comments you may need in the comment section. I'm going to be turning it over now to our host, Jessica, for the day, and thank you again for joining us.
Thank you, Daniel. Good morning, everyone. We're excited to have so many people join us for our first session of this year's 2025 RAAM Knowledge Exchange Days. We have with us presenting on an introduction to substance use disorders in the RAAM clinics, Dr. Knight. Dr. Knight is a fellowship-trained addiction and family medicine clinician. She completed medical school in Manitoba with her residency in UBC in Vancouver, which was followed by an addictions medicine fellowship at St. Paul's Hospital. She holds CSAM certification as a certified and a certificate of added competency in addiction medicine. She practices both family and addictions medicine in a variety of locations within Winnipeg and across our province. She is also the medical director of addiction services at HSC, medical lead for the RAAM clinics provincially, and medical director of Island Lakes Addiction Program with Four Arrows Regional Health Authority. She also serves as the inaugural program director for the Addictions Medicine Enhanced Skills Residency Program at U of M, which began in 2021. She is currently president of the Canadian Society of Addictions Medicine, and her interests include health systems, medical education, focusing on improving access to evidence-based addiction services, harm reduction, and treatment options. So on that note, welcome Dr. Knight, and I will turn it over to you.
Thanks so much. I'm just going to get my slides up here. So today's talk is really an introductory talk, sort of looking at what are we talking about when we're talking about substance use disorder, and also what are we talking about when we talk about substance use in general, because the two are not the same. These are all my roles. I don't have any specific conflicts of interest. I don't have any role with pharma or any other potential conflicts related to this topic. I did want to start with the land acknowledgement. I'm calling in today from Winnipeg, so Treaty 1 territory. I've had, while I've practiced mostly in Treaty 1 territory, later today will be up in Thompson, so in Treaty 5. I've had lots of opportunity of living and playing and working in a lot of the territory in Manitoba, and also learning in areas in BC as well. I think it's really important for us, particularly working in the realm of substance care, to be mindful of our history with colonization and the impacts that has, and the impacts that land can have in terms of recovery. So the connection with land can be a big part, and the reconnection to culture can be a really big part of people's recovery journey as well. So the learning objectives I have for today are to be able to appreciate the difference between substance use and substance use disorder, to be able to engage in conversations around substance use with language that reduces stigma, and to be able to know about evidence-based interventions for treatment of substance use disorders, including some of the relevant both learning opportunities and local resources. I'm not going to talk a ton about RAAM, actually, because I think lots of people know about it, but I'll talk broadly about resources, and RAAM will be one of them. So I'm going to start us off talking about some of the basics of substance use in general. If you have any interest in history, the history of substance use is quite fascinating, and particularly the overlap of substance use and medicine actually is a really fascinating topic. But one of the things that is really important for us to realize when we're working in this space is that substance use is normal. It is an absolutely normal human behavior for people to look for a mind-altered state for a variety of reasons, including novelty seeking, including connecting with others, including spiritual experiences. And so the use of drugs is not necessarily a concerning thing. What we do start to get concerned about sometimes is when people are starting to use substances in a way that is harmful to them. And there's really no difference when we talk about one substance versus another from the perspective of potential harms. We sort of arbitrarily have decided that some substances are okay and some are not. So many of you who are joining today probably have your cup of coffee or tea next to you that we've decided several hundred years ago was going to be a trade commodity as opposed to something that's outlawed. And similarly, we've decided as a society that things like alcohol and tobacco and now cannabis are legal and reasonable for people to use on a social, whereas other substances continue to be sort of illegal and limited to illegal trade. Interestingly, a lot of the substances that we consider kind of hard drugs or illicit drugs today were a big part of medicine, and so were often used in multiple different settings. Were often used as part of these sort of cure-all types of treatments for a variety of diseases. And then as people started to use them more problematically, they become kind of pushed off into the side of society and prohibited, which in it also specifically targets people who are already marginalized more than people who are not. And so it brings in some of the lens of where criminalization of drug use is problematic in its own right. So if I'm saying that substance use is normal and substance use is something that is expected for humans, then where do we get concerned? Where do we care about substance use? And really, it is when people develop a problematic use of substances where their brains are reacting in a different way and they lose control over that substance use that becomes problematic. For a long time, this was understood as a choice or as a moral failing, but really the science tells us that this is by the time that people have a diagnosable substance use disorder, they have a brain disorder that impacts their perception of the substance as the most salient thing or the most important thing in their life. There's lots of evidence that points us towards treating substance use disorders as a chronic disease, and actually the outcomes when we talk about success of treatment of substance use disorders are incredibly similar to successful outcomes for treatment of other diseases like diabetes, like asthma, like COPD. The quote on the slide is one that I use often when talking about the concept of treating substance use disorder as a chronic disease, and where we're missing the mark often within healthcare in being able to do this in an appropriate way. So the example is if somebody is coming into the emergency department or into the hospital with an episode of diabetic ketoacidosis, and we treat them acutely in a really appropriate way by giving them insulin and IV fluids and correcting all of their electrolyte abnormalities. But if we do all that and we don't give them a diagnosis, we don't give them a treatment for their long-term diabetes and we don't connect them to long-term care, that person inevitably is going to come back to the emergency department probably in 2 or 3 days, maybe a week, with the same problem. But when people present to acute care services with substance-related concerns, like alcohol withdrawal or like an opiate toxicity event, they often get that acute treatment for their disease. They get treated for their withdrawal or they get treated for their overdose, maybe get a brief conversation about harm reduction or about treatment, but they don't really get a diagnosis. They don't get an evidence-based treatment option. They don't get a follow-up plan. And then we as healthcare practitioners get frustrated when we see the same people over and over and over again, but we haven't actually treated their underlying disease from that chronic disease model. So many of you who are in attendance today will know this already, but just to highlight that we do have diagnostic criteria for substance use disorders. And again, it gets into the relationship with the substance use and the harms related to the substance use, broken down into the 4 categories of compulsive use, so loss of control, negative social impacts from use, high-risk use or using in high-risk situations, and the physiologic effects of tolerance and withdrawal. We also, based on those criteria, can label the substance use disorder as either mild, moderate, or severe. And it's again based on those criteria that we say that people are either in early remission or in sustained remission once they've no longer met those criteria for a period of time. We also sometimes will have qualifiers. So, for example, somebody who is in sustained remission on an agonist therapy like buprenorphine or methadone would be in sustained remission on an agonist treatment. We also will add a qualifier for individuals who are in remission but in a more controlled environment, just appreciating that somebody who is in remission, for example, in a treatment program or in a sober living situation, that situation is somewhat different than somebody who is in sustained remission or in early remission in the same, like at home in the same environment where their substance use disorder became problematic in the first place. There's a lot of different behaviors that sometimes are sort of flags to think about whether somebody has started to develop a substance use disorder. And so again, when you're sort of talking to people and having conversations around substance use, it's not always that people will give you kind of the a straight answer if you ask them specifically about all of those criteria, but when you're getting to know them and they're telling their stories, you can often pull out some of those things from their history. But again, really appreciating that most people who use drugs and alcohol actually don't have substance use disorders. And just the fact of using a drug doesn't necessarily mean that drug use is problematic. That said, substance use disorders are common. This is getting to be older data now, but it's been pretty consistent over the duration of time that we've been looking at it. So looking at in Canada, a lifetime prevalence of over 20%. So over 1 in 5 people will have a diagnosable substance use disorder within their lifetime. And within the prior year, in and around that 4.5%, 4.4% of people will have had a diagnosable substance use disorder within the prior year, and that's excluding nicotine use disorder. It is also a very, very common reason why people are admitted to acute care hospitals across Canada. If you remember back to 2021, it was a year where there was lots of COVID still happening and lots of COVID response still happening. And during that year, substance use disorder was the 5th leading cause of hospitalization across Canada. That was after the top 4 were COVID, giving birth, acute MI, and heart failure. And after that was substance use disorder as the primary cause of hospital admission. We're going to talk a lot about treatment today, and we're actually going to talk both about treatment and harm reduction in detail, but just want to highlight as well this concept of the 4 pillars of addiction medicine. So any response to substance use disorders or addiction really does require a response in all of these 4 pillars to be successful. And so we often neglect prevention quite a lot, but prevention is one of those 4 pillars. We talk a lot about harm reduction and treatment. We don't talk a ton about enforcement, and enforcement doesn't necessarily mean criminalization. Enforcement also means just the regulations around substance use. So it actually also includes things like decriminalization or legalization and regulation of drugs. So things like the Portuguese model of decriminalization, but direction to treatment for problematic substance use would fall under that enforcement category of interventions. I did want to spend a minute talking about it now, the concept of these 4 pillars, because oftentimes they're spoken about as being in opposition to each other, or as being sort of focusing on one versus the other, particularly when it comes to harm reduction and treatment. But really, we need to focus on having availability of services within all of these 4 pillars if we're going to have any real impact, because focusing just on one will not meet the needs of a lot of the people who are impacted by substance use disorders. So the next section of this kind of introductory talk is going to shift into talking about language for a little while. We're going to talk about words specifically, but we're also going to talk about the content of conversations and matching content to stage of change for individuals. For those who work in the sector, if you've worked in it for a long time, you probably have noticed a change in language over the years, really moving towards, if you want to think about sort of a core concept of language and how to apply it to working within the substance use disorder realm, is shifting to person-centered language. So getting away from some of those terms that lump together the disease and the person. So things like alcoholic or drug user or IV drug user, where the person and the behavior is one, to using person-centered language, where the person is an individual who may have a particular behavior or a particular disease. So a person with alcohol use disorder, or a person who drinks, or a person who injects drugs, which just separates the person from the disease, and appreciates that individuals who struggle with substance use are first and foremost people who have a complexity to them like everybody else. Some of the other language that I would encourage you to think about and try and be mindful of in your own practice is using the word clean. This is a tricky one because a lot of patients and a lot of family members and people in recovery themselves will often use this language. But if you try and unpack it a little, if somebody's referring to themselves as clean, or you're saying that they've been clean, the opposite of clean is dirty, and dirty is typically looked at as bad. So if I am clean, that's fine, but if I'm not clean, then I'm bad because I use drugs. And so it just reinforces some of that morality to substance use, and can increase some of the stigma and the shame that people can experience that prevents them from accessing care or delays care if they have a return to substance use. So just being mindful of that, and being mindful of as care providers, trying to avoid using those terms, and shifting in to using something like, if we're talking about a person, if they're in recovery, or if they're in remission, or if they're in wellness, something like that that lands for the individual. And if we're talking about results on, say, a drug screen, that they're just negative for whatever substance we're talking about. So they're negative for opioids, as opposed to it's a clean drug test. A couple of the other ones that I've included on the slide have previously been very sort of normalized and well accepted terms, but one of the ones that we've tried to get rid of is this concept of alcohol or drug abuse. It doesn't exist anymore in terms of DSM-5 diagnostic criteria or language. And again, is a word that is just got lots of negative connotation and lots of sort of morality tied to it. So we're just shifting into talking about either alcohol or drug use, or high risk use, if that's more appropriate. Those are the ones that I wanted to really pull out. If people have questions about others, we can certainly go into them. Another piece about language that I think is really important is just recognizing that language changes a lot. And it changes not only with time, but it changes with location as well. So there'll be pockets that will refer to a drug or a type of drug use with one word in one area that will be different in another. There's really no way to know what people are talking about unless you ask them. It is okay to ask people to sort of elaborate on something if they say a word that you don't know what it is, particularly if you're just very clear. And sometimes it can actually be a really good tool in terms of building rapport with people and building trust. Because it can put you as the care provider into that learner role and sort of equal out the playing field. Because if you can imagine somebody with a substance use disorder seeing a physician or a healthcare practitioner, oftentimes it really can feel like there's a power differential there. So shifting the individual into a teacher role and learning from them can even that out a little bit, and work towards building a strong relationship. And the only way that most of us will stay up to date on language is just to ask people what they mean when they say something new. There's a few things that I've put in kind of bold here that are just kind of common terms in Manitoba. So methamphetamine, for me, most people will talk about it as ish. Jib is still somewhat common, but ish is the most common that I've come across. And then often the fentanyl containing products that people are talking about are often a variety of different kinds of down, but there are terms that evolve all the time. So this next piece about language is really just trying to make sure that the conversations we're having with individuals are actually the right conversations. If one of the important pieces when you're starting to get to know somebody, or when you're doing an initial having an initial conversation, or broaching substance use with somebody who is seeking services, is to try and sense and try and get some indicators as to where they are with relation to their substance use. And it might not be the same for every substance either. Somebody might be entirely in preparation or action phase for one substance, but entirely pre-contemplative on another. And so it's not sort of a catch-all for substance use necessarily. But being able to kind of pick up those cues and see where somebody is at will help you to tailor your conversation so that it lands. So if somebody is really pre-contemplative, that's where we are best off using harm reduction initiatives and engaging with people with our skills around motivational interviewing to try and kind of shift a little bit more to change talk. If they're in that contemplative phase where they're seeing both pros and cons to their substance use, they're not sure what they want to do, then motivational interviewing again is motivational interviewing and harm reduction again are very, very appropriate, but we might get more into a little bit of information sharing in terms of what are people's options if they want to start thinking about moving forward. And if somebody is really in that preparation or action phase, that might be where we start actually talking about medications that we can use for withdrawal management or for relapse prevention, and getting people connected to formal services like detox or treatment programs. I referred to MI or motivational interviewing in the previous slide. If you haven't had an opportunity to do formal training on MI, this is a super, super useful tool. And it is something that most healthcare providers are naturally bad at. It really requires you to walk alongside individuals, to actively listen and to actually not try and fix things for the most part. When you're having a really good motivational interviewing conversation, the individual you're interviewing is actually doing most of the talking and you're just kind of synthesizing and listening and reflecting. But there's a couple of really sort of easy tools or easy tricks to having motivational interviewing conversations with individuals around substance use. One of the most useful ones that I found in my practice is actually asking people what's good about their substance use. What is it doing for them? What are some of the reasons that they continue to use substances? And this is useful even in the context of somebody who's very pre-contemplative, where you might want to try and focus on the negatives so that you can move them, but actually asking what's good about it acknowledges that there are reasons that people use substances that are good reasons and that are valid reasons, and so that places you as a safe person to talk about substance use with. So it helps build rapport. But it also sometimes actually gets people thinking about the opposite. There's this natural human tendency of sort of arguing the opposite side. And so if you start by asking people what is good about their substance use, sometimes they can't actually come up with all that many things. And they start sort of thinking about what are some of the negatives and what are some of the reasons they might want to change as well. I have a couple of other ones on the slide there, but I'm going to actually just stop with those, that one for now. We can make the slides available if people are interested. So the next section of this talk then is moving into evidence-based treatment options. So this is going to be a relatively short part of the talk. Yeah, relatively short part of the talk, just going over what are some of the key evidence-based treatment options that we have. And then we're going to have a section focused on harm reduction and an overview of the resources. So before we get into the nuts and bolts of what are some of the evidence-based treatment options for substance use disorders, I think it's really important to acknowledge the barriers that exist to treatment. There are a lot of them, and it is there are barriers that exist in a bunch of different levels. I've categorized them here in terms of barriers of stigma, wait times, and funding, but there's lots of different ways you can categorize these. Stigma is a big one. if you remember that quote that I started off the talk with, comparing to diabetes, we certainly in healthcare treat substance use disorders different than other chronic diseases. So they are more stigmatized. It is less likely that people get evidence-based care in most healthcare settings, and we're working on that. And all of you are part of the work on that because you're here. But there continues to be significant amounts of stigma that cause treatment delays. There's also internalized stigma, so this kind of long-standing concept of morality related to substance use and of lack of will related to substance use that often people feel like they should be able to change without help. And so that can often be a barrier to people seeking help and delay connection to care as well. I'm sure nobody here is surprised to know that there are wait times. There's wait times for sometimes getting even into a clinic because we might be full one day and have to push people to the next clinic. There's certainly wait times in terms of getting into withdrawal management services, whether that's medical or non-medical withdrawal management services. And then if people are seeking either outpatient or bed-based treatment programs, there sometimes can be multiple month waits to get into those kinds of treatment, particularly if we're talking about the public sector where people don't have, where there's no additional cost to people accessing service. But even sometimes if you're looking into the private sector, it doesn't necessarily mean you can access treatment today. And then funding is an issue that I think is underappreciated, to be honest. But things like medication coverage can be a big barrier to folks being able to access treatment, particularly if individuals are working, but are working in positions that don't have good private coverage plans. So sometimes people who are working sort of minimum wage jobs or kind of labor jobs, things like that, where they may not have private coverage, but they also don't qualify for things like EIA or don't have treaty coverage for medications. Similarly, there's only a few programs that are broadly covered by Manitoba Health. So all of the regional health authority programs are covered if people want to go into a bed-based treatment program. But otherwise, there's actually cost associated with programs. It's covered if people, again, have EIA or have treaty coverage. But if an individual wants to access a treatment program that is not one of the regional health authority covered programs, there is a cost to attending those programs. And then just kind of systemic underfunding, substance use disorder, both prevention, harm reduction, and treatment has been underfunded by both provincial and federal governments for basically all of existence. So moving then into some of the system and some of the kind of pathways and supports for individuals. I'm not going to spend a ton of time looking at this. This is just something that I put together a couple of years ago to kind of give a broad overview to what is out there in Manitoba from kind of a lens of a treatment algorithm. So including things like harm reduction if people are not looking to access treatment programs. I've included in here the connection to RAAM or primary care, as well as the connection to the Manitoba Addiction Helpline at any time if people want to access care through those services. And then kind of both medical and non-medical withdrawal. What are some of the outpatient and consultation services, some of the places where people can access medication management for substance use disorders, and then a summary of some of the in-house or bed-based treatment programs that exist based on kind of categorization of ones that are run by the SDOs, which are covered by Manitoba Health, some of the longer term treatment programs, some of the ones that are private, First Nations, and community or faith-based. So the next couple of slides break down sort of treatment into different categories. So starting with medications, just appreciating that there are good medications for a few substance use disorders, not necessarily for all of them, but we do have good medications for alcohol use disorder, for opioid use disorder, and for nicotine use disorder. And I've included the nicotine use disorder because it's often undertreated. There is actually strong evidence that if people are willing to consider smoking cessation, they have a better chance of quitting smoking when they're quitting something else, because all of the strategies are the same, all of the kind of neural pathways to smoking or to nicotine use disorder are the same as other substance use disorders. So it's something that we really should be screening people for and supporting them through when they're connecting to RAAM resources or to other treatment resources. There's a number of different consultation options. If you're working in primary care and you have an individual with a substance use disorder that you want some support in terms of what are your options, we do have eConsult, which is a really good web-based platform. If you've got a question that can wait a few days, maybe you would just want some advice for the next time the individual is going to be in your office. Currently, I answer all of the e-consults, and for the most part, am pretty good at getting you a response within 7 days, unless I'm on holidays or something. The race line is a good opportunity if you've got somebody with a more complex mental health condition as well as substance use disorder and you want some advice around medication options or treatment, staffed by the CODI psychiatrists, so really more for that kind of co-occurring sort of population, but can get sort of a same day answer, some recommendations in terms of treatment. For if you're doing hospital-based work and you need, you've got somebody admitted to hospital and you need some advice in terms of management of their symptoms, we do have an addiction doctor on for hospital-based addiction consults 7 days a week for providing advice for people who are admitted to hospital. And then I run the Karma Clinic out of Health Sciences Center, which is really intended as a consultation clinic for more complex substance use disorder questions that we then provide recommendations back to the referring physician, who's mostly primary care physicians, although we're open to consultations from specialists as well if they're following somebody longitudinally. In terms of withdrawal management, the big thing with kind of figuring out what withdrawal management is necessary is what kind of level of support do people need. So most of the time when people are talking about detox, they're talking about the non-medical withdrawal management services that exist within the province. So here in Winnipeg, where I am, that's operated by the Main Street Project, both in the male and female identified services that they have. There's also non-medical withdrawal management beds in Thompson and in Brandon that are places that people need a medical clearance for, and that will include prescribing of medications that they take regularly for chronic diseases, but also prescribing of medications if they think they might be necessary for the acute withdrawal phase. But there's not the opportunity to have people assessed by nursing or healthcare on an ongoing basis and using like as needed medications. So really for people who are not thought to be at risk of severe withdrawal. There's community-based withdrawal management. So here in Winnipeg, again, that's run by Clinic with a K, so Mobile Withdrawal Management Service. There are some expansion of mobile withdrawal services across the province happening currently. So there is a mobile withdrawal management service in sort of Portage area in Southern Health. And I believe there's a couple that are sort of in the midst of being rolled out in a couple of other areas of the province as well. And then sort of the highest level of care is the medical withdrawal management services that are in hospital settings. So the longest standing one being the addictions unit, which has 11 beds within Health Sciences Center and is really targeted towards providing support for medically complex withdrawal, which generally means people with a history of alcohol withdrawal with seizures or delirium tremens, but sometimes also other complex situations, for example, pregnancy, or sometimes if people have a more complicated opiate agonist therapy start and require some additional stabilization. There are some new medical withdrawal management beds in Brandon and in Portage as well. And just also an appreciation that withdrawal is treated basically in every emergency department and in many hospital wards across the province as well. Peer support is important to know what is around and what is available within your area. Peer support has often been a really key part of individuals' recovery. The evidence behind it is not as strong, but often really the key message is if people find it helpful, then they should attend. And some of the important things to know about peer support groups when you're talking with individuals is that there are some different ones that are available. There are the 12-step ones that are based on Alcoholics Anonymous, but there are also some expanded options for non-12-step as well, looking at things like Smart Recovery, which is a little bit more standardized, is non-secular, doesn't have any religious content to it, so it can often be a really good opportunity for people who don't connect to 12-step for some of those reasons. I alluded to this earlier, but when we're looking at treatment programs where people go live at, so like bed-based treatment programs, there are only certain ones that are covered by Manitoba Health. And so almost all of the treatment programs generally are self-referral as well. So there's not necessarily a lot that healthcare providers need to do to support people other than making sure that they know how to get connected to the individual treatment programs. I've included here the information regarding the youth intakes. Some of this will change in the next little while as the youth intake service switches. But for now, if you're working with any youth who are looking for addiction services, YACI is kind of the entry point to everything, including the entry point to the voluntary stabilization unit at YASU. As I said, I'm not going to talk a ton about RAAM today because largely lots of people know about it already, but just a reminder that this is a good resource for people who live in areas around the 7 clinics. The concept is low barrier walk-in addiction care in an interdisciplinary team, so people can see the person that they need to see, whether that maybe sometimes is everybody as part of the team, but sometimes it might be that they predominantly need to see the counselor for a referral to treatment, for example. in which case they're just able to connect with the individual that's the most appropriate. For all of those folks who are out in primary care and maybe doing starting to do some OAT in primary care, we also have a physician on call for RAAM, and that can be a backup support to providing that substance use disorder care within primary care as well. These are some of the key resources that I give to people if they want to learn more, or if they want some resources, including things like recommended order sets or practice manuals. So Medify is out of Ontario and has really good evidence-based protocols. The BCCSU is out of BC and provides creates a lot of the clinical practice guidelines related to substance use disorder care. They also have a really excellent online training program that is sort of comprehensive overview of substance use disorder care that is accredited and that is free. The CFPC's member interest group in addiction medicine creates a number of good tools for predominantly targeted towards primary care providers. All right, so we've got a few minutes left. The last section I wanted to spend a good amount of time on is harm reduction. So again, just reminding folks that this is one of the major pillars of substance use disorder policy and care, and that it is not instead of, but it is in addition to and complementary to the other 4 pillars, including the pillar of treatment. So harm reduction really is just a concept of identifying somebody who has a risky behavior of some sort, and how can we support that individual in reducing the potential harm of whatever that behavior is. So we talk about it in substance use disorder care a lot and in substance use health a lot, but we actually do it in all sorts of settings. If you wore a seatbelt the last time you were in a car, that's a harm reduction initiative. When you're talking to somebody about their diabetes management and you're looking at if they can change their pop to a diet soda, that's a harm reduction initiative. So really looking just at behavior change and reducing risk of specific behaviors. There's a bunch of substance-related recommendations that fall into harm reduction. So the Canada's Guidance on Alcohol and Health is one of those that outlines what are the increasing risks as people's alcohol intake increases, not only related to substance use disorder, but also related to other chronic health conditions that are caused by alcohol. There's also lower risk cannabis use guidelines that I'm not going to go into in detail here, as well as lower risk cannabis use in the context of psychosis. These ones are a little bit newer, but for people who either have a past history of psychosis or a high risk of psychosis. One of the main interventions related to substance use in terms of harm reduction is supply distribution. So this is the concept of giving people safe supplies to use drugs in the way that they're going to use them anyways. So things like distributing needles and the related paraphernalia that has really strong evidence in terms of reducing high-risk injecting behavior, like sharing needles, reusing needles, and has substantial reduction in HIV infection and other bloodborne infections. This is broadly supported by evidence and really does should be available to anybody who uses drugs. Supervised consumption is, again, super evidence-based. This is an area that there's been lots of public discourse about over the last number of months in a variety of different places, but really the evidence base suggests that this is strongly supported in terms of, again, some of those shifts towards more safer drug use, as well as being cost effective in terms of the cost savings related to health and other outcomes. Naloxone distribution, I'm sure most of you are aware of some of the key points about naloxone distribution. If you are ever working with somebody and you don't know where to point them to get a kit, you can look on the Street Connections website, and that's a good place to find where there are distribution sites for naloxone. It's also, if you're working with individuals who have treaty coverage, it is covered by treaty. It doesn't actually require a prescription anymore, but sometimes it can be helpful to give people a prescription just so that they don't have to sort of describe what they're looking for to the pharmacist. And treaty covers the intranasal option, which is not covered by public health in Manitoba. When we're talking about harm reduction for people who are using drugs, there is a number of different sort of categories of structuring a conversation around substance use. Certainly the methods, the location that people are using, and I wanted to highlight NORS, which is a phone-based overdose prevention service that people can use if they are using alone, so that they can have support of somebody over the phone as an overdose prevention. And then some really specific kind of things to share in terms of teaching people how to inject in a safer way, highlighting also that people should be accessing STBBI testing every 3 months if they have ongoing at-risk behaviors, including injection drug use. And then if people are using methamphetamine, focusing also on some psychoeducation around methamphetamine psychosis, and some rest days to have some catch up in terms of nutrition, hydration, and sleep. And again, just wanting to highlight this as a resource for individuals. Katie is a really excellent producer of harm reduction materials, and you can register and order these materials for your clinical setting at no cost, so that you can have them available to individuals who are accessing your services. So that brings me to the end, which is great because we've only got a few minutes left. So just wanted to highlight some of the really high yield resources for individuals who are practicing within Manitoba, to be able to have to provide to your patients and the people you're working with. And then just going back to the summarize, to the summary of some of the take-home points, which is, again, just appreciating that substance use is normal human behavior and not all substance use is related to substance use disorder. Substance use disorders themselves are common and are chronic medical conditions that can and that should be treated within the healthcare system. And we can all impact stigma around substance use by normalizing both substance use and treatment. We can do this by having conversations both in our clinical settings and in our private settings and kind of social settings about substance use, using non-stigmatizing language and being mindful of the language that we use. Particularly within our work settings, support evidence-based treatment options and the use of those within both our medical settings and other places where we might work. And by engaging with people who use substances using trauma-informed and harm reduction approaches. And that is all I have for folks today, as kind of a brief introduction to substance use.
Thank you so much, Dr. Knight. Always a fascinating presentation, so much information. We have a few questions in the chat. One, and I believe you mentioned at the beginning, if you were make your slides available. We are going to be posting these. We're going to work with our communications department to get them posted, and I suspect we can find a way, if you're available, to share your slides to add that in with the video posting. And then the other question we had, although I think you to a certain degree answered it in that last slide, And given where we are on time, I would encourage folks to attend some of our other sessions, which is how do we push back against, or how do we reply to push back against providing and sharing harm reduction supplies? If you have one quick thought, but otherwise, yes, I'll encourage people to attend some of our other sessions on the topic.
Yeah, it can be a really tricky conversation because oftentimes people feel like, again, sort of that moral response to substance use is that if we're giving out supplies, that is encouraging people to use drugs. But all of the research evidence and all of the science around this says that it actually reduces harm. So it's actually more unpacking the individual's response that I think is sometimes helpful. There is oftentimes too sort of a sort of religious component to it, or an opposition that comes from somewhere else. So I have a couple of good resources. One that is a book actually that was written by a colleague of mine that folks might be interested in looking at, that has really given me a good way to think about engaging in those conversations with people around harm reduction. Has a book called Why I Help People Take Drugs, and written from the perspective of an addiction physician who has a background in the kind of Christian ministry, and so really helpful in terms of framing some of that conversation around morality and substance use. That I would encourage people to take a look at. I've got a copy if anybody is in Winnipeg and wants to borrow it.
Awesome. Great suggestion. Always good to have those extra resources. We are out of time for today. We do invite everyone to join us for our next session, which is a panel discussion on harm reduction activities in Manitoba. That is a separate link, so we are going to end this meeting. Again, thank you so much, Dr. Knight, and hopefully we will see you all at the next session. Thank you.